All right. So today I thought we haven't done a frozen session in a while. And I know, head and neck are one of the most common ones, obviously, that we get. So I thought I would do head and neck frozens, mostly focusing on kind of squamous lesions, um, but also touching on just a couple of other points. So if, like we used to do in the past, sitting around the multi-headed scope, just look at these impromptu. So if you didn't get a chance to preview, that's totally fine because when you're doing a frozen, you won't have any time to, quote unquote preview or think about it very long. So we're going to practice that technique. So if it's okay with you guys, hopefully each of you can sort of take one. If you want, I can give you driving abilities so you can drive it around yourself. At least maybe let's try with somebody, see if that works. If it doesn't work, I can drive it, but I would like to see if we can do that because I think it'll give you a little bit more control. So who is going to be my first volunteer? I put the I don't know if everybody could see it, but I put the histories in the chat. They're also linked. In that little paperclip. Where'd it go? They're also linked in the paperclip icon.
Oh, it's blue on the mid
yeah,
right.
there's something in it. Yeah, okay. Yeah, so that's it. Okay, who wants to be my first volunteer?
I can go ahead. I guess I will just request remote control.
Mm-hmm.
Okay.
Thanks, Heather.
Let's see. Okay, wait, let me figure this out. All right, now I think I've got it figured out.
Got it.
Okay,
right. This
great.
is a deep tongue margin on a tongue SCC. So, this is just a tumor bed margin plucking from the deep skeletal muscle in a patient first.
Yeah.
Yep.
It looks like maybe we have most of the tissue here. I guess that's like the first thing maybe we should note in like our frozen biopsy, whether or not it's like the representative face. And yeah, so it looks like, we are in the tongue. So this is going to be mostly made of skeletal muscle, as we see here. So yeah, they're looking for if there is carcinoma here, yes, no. And I think there is an area here. I can drag my way over. It was like somewhat questionable.
Yeah. For
presence of carcinoma. Like, this looks different from the rest of the tumor, not tumor, the rest of the normal skeletal muscle. It does look squamous. We've got like these like very, let's see if I can annotate this, like these like abnormal looking cells, or nuclei, and like a lot of inflammation too, probably, because of the surgery as well. I mean, I'm inclined to say this one is, but it's also detached from the rest of the main specimen. So it's like a little, but I'm inclined to, say this is positive because like this part is like also, right up against the skeletal muscle too. So I would, if it were me, I'd probably call back and say, yeah, it's positive for carcinoma. I want to take a larger margin.
Okay. Yeah, so thank you. So I'll grab control back again. So one of the things I think that you said that is quite important in this case is it attached or detached? And in this case, whatever this fragment is, and maybe that little strip seems to be sort of plastered on the edge of the skeletal muscle rather than within it. And these other areas that you see cells, I don't know, it's overlapping, kind of potentially inflammatory. And then there's this one piece of tissue here that is detached. I would argue detached and potentially not part of the tissue. So you could definitely do deepers to see if it becomes attached. Do other people have any concerns or questions about what this is? Are you convinced that these cells are squamous? Are they cohesive? Do they have well-defined cell borders, dyskeratosis, et cetera? Does anyone have any other thoughts about? So Luke says granulation tissue. Okay, all right.
I mean, I agree that the vascularity that we're seeing, the degree of inflammatory infiltrate is pretty consistent with that. In that setting, it's tempting to call these large ugly cells, histiocytes, although the strong prominence of nucleoli is a little bit alarming even in that setting.
Yeah, concur. So one, it's not extremely vascular. It's a little more inflammatory. Two, I always heed prominent cherry red nucleoli because those generally aren't found in many benign conditions. So you mentioned potentially histiocytoid types of cells, potentially, epithelioid cells. So without belaboring this point too badly, does anybody have a definitive answer as to what this is, or do you want me to just shout it out? Oh boy, you're really breaking up. Can you try that
Can
again?
it be like nasopharyngeal carcinoma cells can have this prominent nucleoli?
Okay, so nasopharyngeal carcinoma cells, yep, can have prominent nucleoli. Melanomas can have prominent nucleoli. Lymphomas can have prominent nucleoli. Certainly, many malignancies can. Would nasopharyngeal carcinoma, for example, fit in this tongue?
No,
No.
it looks detached. And there's no epithelium also with the.
Yeah, so when you're in the deep margin, you wouldn't be expecting any epithelium necessarily because they're taking it literally from the muscular bed.
Okay.
So any amount of diseased tissue or squamous or whatever would theoretically either be considered positive or some kind of artifact. And so I found this frozen to be hilarious because this piece of tissue looked extremely odd to me. And I said, why are these individual isolated prominent nucleoli cells floating around in this background of lymphoid tissue that's detached from the main specimen? And it turns out that just immediately, yes, thank you, floater contaminant, just immediately prior to this, there was a frozen that had Hodgkin's lymphoma in it. So this is Hodgkin's lymphoma. As a floater contaminating a tongue. So this is when you see something that is out of place, that is detached from tissue, always be quite cautious because number one, you can get a contaminant in the operating room, right? If they're using the same forceps, to take out tumor and then to take out negative margin. So one, you can get an intraoperative contaminant of the actual same patient's tumor to a negative margin because the surgeon put it there with his forceps, which we've seen, or you can get a pathology contaminant where the cryostat has floating bits of Hodgkin's lymphoma or meningioma or whatever. So this is Hodgkin's lymphoma. So we thankfully recognized this abnormality at the time of the frozen and communicated with the pathologist, from the morning, and they said, oh yeah, there was a Hodgkin's lymphoma, that's it. So just always, if something is marginally out of place or detached, just hopefully your spider senses will kick in and you'll be able to identify that this is in fact not a positive margin. This is totally a contaminant. But it got transferred. And this was on multiple levels. So now it's in the OCT. It's not just on the cryostat. So it probably got on the forceps, floated, jumped, whatever, I don't know. But anyway, I think you guys appreciate the, challenge and significance of this.
So the thought is, was it known in this case, like where in the frozen workflow the contaminant originated? Like, was it in the freezing well? Was it on the little plastic spatula or stuck to the lip of the OCT bottle?
It was not determinable.
Okay.
I think the only thing we knew was that the same cryostat was used. So could have been on the forceps, could have been on the chuck, could have been on the plastic. Nobody really knows.
Scary.
Scary is right. All right. Thank you guys. Other comments? All right, who wants to drive next?
Might be a good one for a junior, but I'll go if no one else wants to. Here, request control. Oh, awesome. It's not too laggy either. Okay, so this is the vocal cord lesion biopsy. In contrast to the last case, we definitely have squamous mucosa here. Just to orient ourselves, it's a little bit twisted. I mean, I see a basal layer. You guys see my cursor, right? I
Yeah.
see a basal layer here. I also see it up here with the epithelium still going downwards in both cases. So if it's one strip, it clearly got folded onto itself. You know, finding the basal apical orientation is, you know, is very easy. Initially, I got startled because I thought this could have been a super basal or mite right here, but then you notice it kind of has the same sort of quality of staining as the schmutz out here. So this is stain precipitate, or it's not a mitosis. So don't get excited about that. I mean, not, you know, going hip firing here a little bit. My impression is that this is, you know, benign squamous epithelium. I don't see any substantial dysplastic features. Yeah, it's a little bit disorganized, but I don't see a lot of nuclear atypia. I certainly don't see any definitive basilar or suprabasilar mitoses, and I think we have pretty good base surface maturation, at least with this sampling. So I'm not very excited by this.
Okay. Thank you. So yeah, so this is definitely definitely you've got, you know, squamous mucosa here. It seems, you know, no issues with contaminants here. Definitely some kind of basal type of layer with potentially maturation and, you know, maybe a little bit of disorganization to the nuclei. And so I believe this was called no evidence of tumor. And so one of the things on these microlaryngoscopic biopsies that I just wanted to mention to you is, as you all know, Dr. Baird and cohort can send these very, very, very tiny pieces of tissue that I know you don't want to cut through. Initially, I think that's fine. If you get an initial frozen level that has some tissue on it, yes, they're small and they're transparent. You can stain them with eosin if you want to see them better as you put them in the OCT, like sometimes they do for small, you know, GI biopsies or whatever. You can tinge it with tinge it with eosin before you put it in the OCT. And you have my permission to cut multiple levels through this tissue, because the most important information that you can give him is going to be intraoperatively. And as I've told many of you, once the tissue is taken out of the OCT, thawed, reprocessed, re-embedded, and refaced, one of two things can happen. Either it completely goes away, or if you haven't cut into the block enough, you'll actually get the diagnostic answer. So this is the actual, so do I have a measuring tool here? I think I might, because I want to understand the difference here. So let me see if I could, no, that's just drawing. No, is there an actual measuring? No. Anyway, okay. I can't measure this, but that's fine. So clear all drawings. Clear. Hold on, mouse. Clear. Great. All right. So this is the permanent level from this same patient. So this is another potential pitfall of these tiny laryngoscopic biopsies, is that if the tissue is not faced adequately at the time of frozen, there can be inappropriate and artifactual diagnoses that are really not reflective of the tissue underneath. So I don't think anyone has a problem understanding that this is invasive squamous cell carcinoma. It's incredibly architecturally irregular with dyskeratoses. And so one was probably looking at this fragment over here that could have been a tangentially sectioned either surface, dysplasia, or a very, 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 very well differentiated component of the carcinoma. So always try to match up the sizes. And if you think you haven't completely faced the tissue, as I said before, you have my permission to do multiple levels to get a full face and give it a correct answer. So, no one is perfect, obviously, but just putting that in your mind for these tiny little pieces, especially these well-differentiated carcinomas that can look very bland, but actually be incredibly invasive. Comments or questions? All right, who's next? How many deepers can or should we go? You can go as many as you and the faculty member feel that you have achieved to come up with a diagnosis. And the best thing I can say is just match the amount of tissue that you see on the slide to the amount of tissue that you know you received and that you can see on the block. So what I do is I carry the slide over to the cryostat and sort of look side by side to see if what I see on the slide is reflected, from the block. And if not, just keep going. And if you exhaust the tissue, like that's okay. That's really okay. Because as I said, if it's that tiny, it likely won't survive processing anyway. In this case, it was large enough that it actually improved on the permanent. So that's, yeah. All right. Who's next?
I can take the next one. Is this the parathyroid guy?
Yep, this is Para. Para for Perry. All right, there you go.
Oh, true. I like the shamrock also on the history
Oh,
page.
thank you.
All right, so let me zoom in here. So this one looked sort of to me like nice thyroid, honestly. We have these follicles of various size, nice sort of compressed follicular cells for the most part. I was looking to see the follicular cells themselves look problematic, but I at least on a very quick preview last night, I guess here we have some that look a little hollowed out, but I don't know if that's artifact. And again, I guess I'm not sure if what they're plucking out here is then like some isolated thyroidy nodule, or whether they're actually like plucking out, a little chunk of thyroid itself. Regardless, I was looking for, our classic parathyroid histology, and again, looking, sort of previewing myself quickly, I didn't see it, and looking now again, hoping maybe something will pop out. But yeah, all I'm seeing really are follicles, some nice like calcium oxalate looking crystals.
Yeah, can you point us one out?
One of these guys, one of those, I think. Or no?
No, that might be
not the best.
There's a yellowish one next to the bluish one. I think your mouse is just to the right. Go to the right.
The right. Oh,
yeah.
This one, okay, more like a shard, a yellow shard.
Shardy rather than globular.
Rather than like globular. Okay, got it. Is this just like a clump of
colloid?
Colloid. Okay.
It's just artifactually blue colloid.
Got it.
I'm not entirely sure why that happens, but okay.
So I feel like I'm surely missing a teaching point here. So if you could elucidate, that would be great.
I think you have caught the teaching point, which is distinguishing. All right, I can take it back, which is distinguishing thyroid from parathyroid. And so, when parathyroid has microcystic change, it can mimic thyroid. But as Perry pointed out, the presence of calcium oxalate crystals within these central luminal spaces is essentially diagnostic of thyroid. And I know we talk about it a lot and don't always see it, but I thought that this section had, at least something that we can say is a true calcium oxalate crystal on a frozen section. So I'm not trying to trick you. This isn't a permanent, this is an actual frozen. So this square or rhomboid or crystalline shaped yellowish thing in the colloid is calcium oxalate, not the bluish rotund thing. But this definitely is thyroid. And so not para, but thyroid. Sometimes there's little exophytic nodules, sometimes there's little lumps and bumps of ectopic tissue floating around and they just pluck these things off. And so yes, thyroid. You mentioned a little bit about the nuclei. I mean, I think generally they look flat and dark. And yes, you can get freezing artifact in the nuclei of thyroid that gives you the impression of nuclear holes, but those are artifacts of the freezing process. And please don't try to overinterpret those little artifactual holes as PTC, which you didn't. Oh, there's another one. So I think this kind of yellow, this is not focused, but this yellowish area here is probably another little rhomboid calcium oxalate crystal. So yeah, so that's it. I just wanted to show you that it can happen and it can help you if you are ever concerned. This, to be honest, this was called parathyroid on the time of frozen, because I think, perhaps the person was like, oh yeah, they're looking for para. Sure, this could be para, could be cystic. Okay. So, frozens are challenging and can be stressful. And so sometimes it's these subtle signs and clues that really help you. But as a pitfall, mistakes and challenges can occur.
Can
All right.
parathyroid have these like colloid mimics? Because like obviously that's so abundant and the calcium oxalate crystals aren't necessarily jumping out.
Right. Yeah. So in the pseudocystic spaces of parathyroid, there can be pale pinkish cerusoid material that can mimic colloid. Yeah, absolutely.
What about those like harder, chunky?
Yeah, the
hard
harder, like this kind of stuff, that's a good question. I think that's perhaps less frequently seen in non-thyroid, but I would argue that's a little bit more of a softer kind of sign. Yeah. So yes, that could also potentially be helpful, but not as strict as calcium oxalate. Okay.
Thank
Anybody
you.
want to go next? Go ahead.
Oh, I just said thank you.
Sure. All right. Larynx biopsies times 6.
I can try this one, I guess, since I just talked.
Yay. I was going to call on you if you did.
I know. I wanted to
for
do
it.
the rule out thyroid. That's the fun one. Or rule out parathyroid.
Rule out. Yeah. Rule in. All right. So these are just more larynx. I think you have control.
It says you are controlling, but I'm not. Oh, did I
You
move
got
that?
it.
There we go. Yeah, so I mean, obviously see the mucosal surface here. There is a lot of what looks like inflammation deeper. It's really hard to tell in this very inflamed area. Kind of have this like nest that jumps out here. Like cytologically, it doesn't look like squamous cell or honestly, I mean, it doesn't like match up to something on the surface that looks like it would be invasive. Kind of has a nice basal layer around it too.
Yeah. And remember, in any area that you have submucosal types of glands, you can have submucosal types of ducts that, progress up to the surface.
I think some of these thinner ones may be like that. Kind of get that at tonsil a lot too. Those kind of like diving pieces of squamous that
right
kind of look funky, but not to the point of being carcinoma.
Right.
It's really just these like really inflamed areas. It's also kind of like crushed too.
Mm-hmm.
But I mean, I don't see anything that looks like cancer in that area. And the cells that are kind of larger that you can make out, like either those same ducts or maybe even endothelial cells that are a little revved up.
Yeah.
So I mean, it doesn't look just nice and perfectly well behaved, but it looks within the spectrum of like reactive to me.
Okay.
I don't know if I'm missing a spot.
So, okay, part one, is there invasive carcinoma or not? I think in this case, I would agree that no, I think that probably is just a duct with inflammation in the stroma. So then, all right, so then we have to progress to the surface.
Like
And
this.
so, then
If there's
I know
dysplasia.
it didn't scan very well. I apologize for that. But I think on the bottom part of the epithelium, that's a little more in focus. In the larynx and in squamous mucosa in general, you can think about it in two ways. Is it something or is it nothing? And so, dysplasia can be considered as low grade, high grade, mild, moderate, severe / in situ. And so I think you first of all, you want to think, is this absolutely something or is this absolutely nothing? For margins on tongues, mild dysplasia is generally considered nothing. In the larynx for these microlaryngoscopic biopsies, sometimes all they're looking for is dysplasia. So I would argue in the larynx, you may want to try to be a little more definitive with your answer of dysplasia, because that's what they're trying to clear. This is a tiny area. They're going to be lasering off the dysplasia. And so by you telling them the amount and extent of dysplasia, that might actually quite help them in the extent that they laser. So there's a little bit of a shift in thinking between the larynx, small microlaryngoscopic procedures, and the and the glossectomies, where they're not going to be shaving, shredding, or lasering the entire patient's mouth for mild dysplasia. So in this case, what do you think about the surface? Dysplasia or
It's
not?
tough. If it is anything, it's mild. I mean, it's not just like a wild amount of like anything atypical. I'm not seeing mites. There's just like a few cells that are like a little like large and hyperchromatic that aren't directly on the basal or parabasal layer.
Mm-hmm.
I don't know where my real my gut thresholds are though.
Yeah, so inter-observer variability in squamous lesions is arguably quite high. All right, I can take over for a second. And so, some person's mild is another person's moderate, and one person's moderate is another person's severe, and somebody's mild is somebody else's nothing. But I'm actually going to direct you to one, the fact that this is a little bit architecturally irregular. So there's these downward kind of budding and branching reedy. Yes, some of them are drawn out and cauterized like little, beaks. Two, in the areas where you have the downward pointing reedy, there does seem to be a basal expansion where, you may see a few layers of disorganized, dispolarized cells. You see some cells here and there that are a little bit larger and darker than their neighbors. You see perhaps in this area, I'm going to point out right here, where these maybe 10 cell layer is potentially expanded from base to kind of mid epithelium, and the nuclei are large and arguably with maybe a couple nucleoli. As you progress towards the surface, one of my, oh gosh, I'm missing all these messages. Mild at best, 2 or 3 tier grading, maybe low grade, no. So everybody's got a little bit of a different, exactly, everybody's got a little bit of a different threshold. But so when you start seeing large nuclei that progress up towards the surface as this one, that are disproportionately large compared to their neighbors, I would argue that's a sign of dysplasia. When you see thickening of the basal layer with expansion and large nuclei, I would argue that's dysplasia. So I think this is some level of dysplasia. It was called mild to moderate on the time of Frozen. Technically, the larynx supports a 2-tiered grading system, low and high. But yeah, nobody seems to complain in the clinical world if you use a 3-tiered system. Actually, I think that might be a mitosis right there. But whether you use a 3-tiered or a 2-tiered, nobody really complains. This was called mild to moderate on Frozen, which I would tend to agree with. I think this area of moderate here reaches, about halfway up the epithelium. So I would agree. And so this is the kind of thing that they probably would proceed to laser ablate in the patient. And so this is the permanent remnant from the Frozen, which, as you can see, once you thaw and freeze the tissue, sometimes you get some increased artifactual distortion and nuclear dysregulation that may be honestly more challenging to interpret. Oh no, this isn't the permanent. This is another.
See, this looks like
this is another Frozen, isn't it?
Freeze and rethaw aside, this looks.
Yeah. No, I apologize. You're right. So I do not have the permanent remnant on this. I apologize. But the grade of dysplasia persisted to be at least moderate to perhaps even focally severe on the permanent. So yeah, that's how I shift my thinking for larynx compared to tongue. We'll see tongue later. But in the interest of time, 8:30, I might just, unless anybody's dying to do this one, I might skip this one because this is a similar issue of very architecturally distorted tissue with perhaps some amount of dysplasia. Let me skip to, all right, somebody take this guy.
I can try this one.
Okay,
Let me take the control.
great.
Okay. But okay, now I'm able to control it. So here we see a strip of squamous epithelium with underlying connective tissue. It looks very, very disorganized again. I'm not able to zoom in this. I don't know for what reason. Okay.
The
Maybe I should just try from this. Oh,
The
no, it's too
scrolling-
much zoom in.
yeah.
It's not working. I don't know
Not
on my
working?
laptop.
Okay.
Yeah. Huh. Oh, I'm so sorry. I don't know why isn't why isn't the scrolling thing working with my laptop. Okay, but like this is a part of the epithelium that again is looking very disorganized.
Mhm.
And then I think I saw maybe small group of cells here that could represent invasive component, but I wasn't really sure about this. Then again here it looks very disorganized kind of epithelium, and I saw some coilocyte like cells as well.
Mm.
No, it's not zooming out for some reason. Okay.
It's going very slowly.
Yeah.
All right, so
Like
compared to
here,
the prior, better, worse, different?
it looks worse than the
Yeah.
prior. Yeah. Maybe with a questionable invasive component as well, as I said earlier, but definitely worse, at least like high grade dysplasia.
Great. Awesome. All right, I can take that back. So yes, so this is in fact worse than the prior. I think there's definitely some challenge with more worser. There's definitely some challenge with tangential sectioning in this case, but I think one can appreciate the fact that there's I like to call this, I guess some call it pink cell change, where in areas of dysplasia, the squamous epithelial cells acquire abnormal pink keratin, not such that it's necessarily quote unquote dyskeratotic, but that if you look at this, you're like, wow, that's really pink. And some of the cells are pinker than others. Like for example, right, this one is quite pink and it has these little desmosomes that attach to their neighbors. But this pink cell change throughout is definitely indicative of some kind of dysplastic progression. There are multinucleated cells, right? There are individual cells that are disproportionately large compared to the others. And so remember, in the larynx and in squamous mucosa, anywhere for that matter, you can have extremely well differentiated dysplasia / carcinoma in situ. And if the nuclear atypia is disproportionate, even if the section is tangential, I agree. I would argue that this is at least high-grade dysplasia / carcinoma in situ with tangential sectioning that makes it very, very challenging to assess for microinvasion. But again, the clinical impression is sometimes important in these cases where if there's very superficial involvement, and whether you call it, in situ or microinvasive may not actually change what they do. They're probably still going to laser ablate and try to get negative margins. And so if you get multiple biopsies on these patients, that's what they're doing. They're not just looking for diagnostic tissue. They're looking to laser ablate and then clear the margin. So sometimes you get normal squamous benign, and sometimes you get respiratory as a negative margin, depending on where they are in the larynx. Okay, does that all make sense? Does everybody agree with this as being higher grade? Is there any definite definition for superficial? No. So superficial and microinvasion, I would regard as synonymous. And I think anything that's on the form of, 1 to 2 millimeters is superficial / micro. If your pieces of tissue are much bigger than that and you have invasive carcinoma, that's probably no longer microinvasion. So I would think about, few millimeters only, but no, there is no strict definition. All right, who wants to drive this one? Honestly, I don't know why there's this like shade over half of the scans. It's very strange. In any event, does anybody want to take a gander at what we're looking at here?
Looks like respiratory epithelium.
Exactly, looks like respiratory epithelium. So sometimes it can be challenging to distinguish respiratory from squamous, especially if you don't see any underlying seromucinous glands. But respiratory epithelium to me tends to have a little bit more of a ragged surface, often with some kind of drawn out cells, finger-like projections, a little more tails to the cells because they are columnar and they could be kind of almost like pulled or like streaming off of the tissue. And so sometimes when you see this furry border or streaming processes to the cells, I would regard this as potentially respiratory. The reason that I mention this is, or like here where half of it is just denuded. So, you know, respiratory epithelium is much more sensitive than squamous. And so it has the tendency to slough off, to fragment, et cetera. And because it's pseudostratified, you can actually get significant amounts of like piled up cells at the base that one might start to think about regarding as dysplastic, but really is just the normal appearance of respiratory epithelium. So this to me is absolutely respiratory epithelium and is normal, non-dysplastic. It just has these piled up nuclei that are normal for respiratory. The cells are of similar shapes and sizes. They're all essentially equally dark. There are none that are super dark or pale compared to the others. So just wanting to point out, one of the other things that you might be seeing on these is just normal benign respiratory. Over here on the right, you can also see that kind of streaming cauterized appearance of the goblet and columnar cells. Make sense? Okay. All right, cool. I think for, again, for sake of expediency, why every single slide has this veil over it? That is like really weird. Okay. Anybody want to shout out what they see here?
The CIS here.
Yeah.
Excellent, excellent. Yeah, so this is a pretty blatant example of carcinoma in situ. And I think, you know, when you're asking yourself, is there something or nothing? Like, yes, this is definitely something. This is definitely at least in situ. And so I don't know, that's when I'm doing frozens with you guys, sometimes I like to ask, you know, is this something or is this nothing? And if it's nothing, you know, we can argue about how nothing the nothing is. But when it's something, you know, again, something or nothing.
This is invasive.
Invasive.
Yeah,
Yeah, it's
exactly. It's much more architecturally complex.
is a
albeit-
deeper level of that same tissue.
No. Totally separate patient. Totally. All of these 6 were just completely different patients, completely different tissues. Yeah. So no, not at all. The deepers on the one we saw before remained at least in situ. And this is arguably completely different specimen, totally invasive. So always be mindful of architectural irregularities and complex branching and budding, because this kind of process is not acceptable for in situ. Okay. Everybody good with this? All right. I think we're moving into the oropharynx.
So I have a question. If you
Yes.
have carcinoma in situ, then we should exhaust the tissue unless we find some invasion, right?
Oh, not necessarily. Not necessarily. It honestly, carcinoma in situ versus invasive carcinoma, depending on the clinical circumstance, may or may not change what they do. Especially in this case where a quite thick stroma, it may just be fibrotic and you may never find any invasion. So you can always have that discussion with the surgeon if they ask, is there any invasion? Because that's going to change my procedure. Then yes, you can level it. But if you say carcinoma in situ and they say, okay, thanks, I think you're done and you're fine.
Okay.
Yeah. And sometimes they do, sometimes they pull that. Oh, negative for carcinoma. Well, is there dysplasia? Carcinoma in situ. Oh, is there any invasion? So it depends on the circumstance. All right, who wants to do this base of tongue?
I can do.
Okay,
I don't know how to take the control.
I think I gave it to you.
I see stratified squamous epithelium lined tissue with a lot of dense inflammation in the subepithelium, and the epithelium looks quite thick
Mhm,
and worrisome now.
mhm.
So I would be looking for any invasion. It looks like carcinoma in situ. No?
Keep going. Yeah, if you're done, I can take over, but you can keep going if you'd like.
It looks worrisome.
Mhm.
The nuclei are quite big, and I can see some mitoses.
Yes. I
But I'm
concur.
worried about this after seeing this.
Mhm, mhm, mhm.
And if I don't see any invasion in the stroma, then I'll go multiple deepers too, unless I find it. But
Okay.
here,
Pretty
I wish
nasty,
I
huh?
had a normal slide than this.
Yeah.
Difficult now.
Yeah. All right. So she's got my mouse. So did this person have a neck met? Did I mention that at all in the clinical history?
No, it was just mentioned as base of tongue biopsy.
Okay. All right. So I may not have that information, but I can take control if you want.
Yeah.
So one, in these base of tongue / tonsil biopsies, these are special anatomic sites. So would you regard this as more of a keratinizing process or more of a non-keratinizing process?
Non-keratinizing.
Non-keratinizing, right? So it's very blue. So, when people ask me, how do you know if it's keratinizing or non-keratinizing? Well, is it more blue or is it more pink? And honestly, it's way more blue. Yes, there's some cytoplasmic keratin, but not to the extent of excessiveness. When you are in a special site like a tonsil or base of tongue that has lymphoid stroma and crypts, and you are dealing with a non-keratinizing, architecturally complex process, this is invasive carcinoma. So as I've mentioned to you before, some of you at Sign Out, et cetera, in these anatomically special sites with complex architecture, with non-keratinizing morphology, this is all broad-based invasion. And so this is squamous cell carcinoma. So at the time of frozen, if you call it squamous cell carcinoma, period, that's fine. If you call it invasive, that's also fine. If you call it in situ, that is essentially not correct for this anatomic area. And in most of these patients where they are plucking off tiny bits or, moderately sized bits from the base of tongue and tonsil, generally, most of these patients have already neck metastases. And so I believe both of these next two patients already had neck metastases. And even though you do not see single cell invasion, these are deep mass forming lesions of the tonsillar crypts that are already biologically potentially capable of invasion. So I like to emphasize this point because calling in situ carcinoma or high-grade dysplasia of HPV associated lesions is not regarded as accurate. And so once you have non-keratinizing process in a special site, you are highly suspicious for HPV and you should not regard these as in situ. So yeah, both of these patients already presented with metastases, and what they're trying to do is find the primary, and they have succeeded. This is, oops, let me grab my remote back. Oops, whoa. Stop, okay. This is the permanent section, which as you can see, arguably has quite a lot of surface-like appearing disease, but it does really, if you call this squamous cell carcinoma period, that's fine. The patient's already metastasized. You've got the answer. They don't have to continue looking for the invasive component. Okay, that's the bottom line. Does that make sense? Am I saying this correctly? All right, thank you. Yeah, so the bottom line is they don't have to go searching for an additional invasive focus. All right, somebody want to drive this one? Or I can just skip this one because it's basically similar. This is another base of tongue tonsil. I'm just gonna, you can look at these on your own and try to distinguish benign from malignant, but crypts, tonsillar crypts can be challenging. And so whether you're at the base of tongue or tonsil or even adenoid, you know, crypt epithelium can be deep diving, can be intermingled with lymphocytes, but generally matures, generally doesn't have a lot of mitotic activity, generally is more pink than blue. And so you're looking for a needle in a haystack at times, you're looking for blue on blue. Oh, here, there it is. So just like in the prior case, this sort of blue on blue appearance of cells that are large, that don't have abundant amounts of intracytoplasmic keratin, that have, ooh, there's a nice mitotic figure right there. Hopefully you guys are satisfied with this being another example of a non-keratinizing squamous cell carcinoma. That's a little bit more obviously invasive, even though it is, again, of a broad-based nature, right? So these nests are rounded. They don't necessarily have single cells, but that's totally appropriate for this anatomic subsite. And here's the permanent remnant. Again, now showing this quite large, bulbous, broad-based focus of invasion. And I'll send you guys this complete link again, so you can have these for your own perusal. You know, but the majority of this tissue is benign crypts. So you'll have that for your review later. Okay. I believe now these were nasal pharynxes. Anybody want to take this one?
I can take it again. Squamous epithelium lined tissue. Lower the magnification.
So what is the special site of the nasopharynx that is lymphoid rich?
Tonsil.
Yeah, so nasopharyngeal tonsil or adenoid. Yep. So you should be seeing respiratory epithelium, which you in fact do.
The epithelium doesn't look like having any dysplasia or anything.
Mhm,
It looks normal.
Yep. What about that piece at the bottom that you were previously at?
I thought it's normal. I didn't. Oh, here, yeah, this layer.
No, way down, even more down. I think you were on it like a minute ago. There.
Yeah, it's just ulcerated with. It's so mixed with inflammatory cells. I can't know if this is tumor cells in the stroma, or is it inflammatory cells only? No, I'm not sure.
Okay.
Yeah, over here, it looks like yeah, it could be malignant cells, but I'm not
Mhm.
sure.
Yeah, so there's definitely some admixture of larger cells and inflammatory cells.
Yeah. I mean, the normal epithelium is not there.
Right.
I don't know. I'm not sure on this. Yeah.
Okay. No, that's fine. It's certainly you're picking up something that is not
But
obvious.
this looks bad.
Okay. Okay.
This doesn't look good.
Okay. I think maybe there's your ulceration or necrosis. There's some fibrin and inflammation and some very large cells.
Nasopharyngeal carcinoma. This also doesn't look good, actually. This
Okay.
looks bad.
Okay, good.
I can only say good or bad.
Okay, yeah, okay. So do you want to say malignant?
I think so. This is necrosis. I think if there is a mass, I mean, in the clinical picture,
Yes, there's a mass.
then I'll think of nasopharyngeal carcinoma, which can be embedded with a lot of inflammatory cells.
But I'll
Excellent.
show
it to someone else.
Yeah, no, all right, let me take over. Does anybody agree or disagree with that?
Yeah, I agree.
I think I agree with the thought of
Yeah.
maybe
Switch
Yeah,
some-
yeah, nasopharyngeal is, I think, a
yeah.
good thought here.
Yeah, so I'm just gonna poke around a little bit because we have some additional pieces of tissue. So you know, yes, the respiratory mucosa epithelium of the adenoid, you would not necessarily expect to be affected. You know, very rarely are there, you know, there's really no necessarily common dysplastic lesions of the respiratory. So we can kind of leave that aside. But, you know, in the background, you have this admixture of very large cells that are arguably, oh, there's a mitosis, there's a dark cell, there's potentially a mitosis. I know that these frozens don't scan extraordinarily well, but at least you can see that the abundance of there's another mitosis, very large cells in the background of a few or more lymphocytes. So exactly, if you, I believe this was called, you know, at least malignant, you know, pending additional workup. But I think you guys all appropriately hit the nail on the head when you referred to nasopharyngeal carcinoma. I think the other option is, you know, could this be a lymphoma? Okay, it could be. But as you know, a lot of nasopharyngeal carcinomas have this almost syncytial growth pattern that, that one's blurry, syncytial growth pattern that can almost mimic a lymphoid process because it's so syncytial. But these large cells with slightly prominent nucleoli are the nasopharyngeal carcinoma cells. So as you were hinting, and when we saw the Hodgkin's, right, you said, oh yeah, nasopharyngeal can have prominent nucleoli. Absolutely, and these do, but I would argue there are many more lesional cells here compared to the Hodgkin's lymphoma, which, you know, the cells in the Hodgkin's lymphoma were spaced apart quite widely. Here they're quite packed together. And so in these types of cases, for the nasopharynx, similar to the oropharynx, they are often doing procedures just to obtain lesional tissue. And so if you can tell them, yes, you have it, you know, just like in the oropharynx, yes, you have carcinoma. In the nasopharynx, yes, you have malignancy, they will stop and say, is it adequate for diagnostic workup? Yes or no? Thank you, move on. And so I'm assuming you can imagine what I'm trying to show you in the next slide.
Yeah, it's the Eber. No, I have a quick question. So like
Sure.
for that, because there's that area with like the glands within the malignant appearing cells, could like biphenotypic cyanide sarcoma be on the differential, or do you think it's just not spindly enough, maybe?
Not spindly enough.
Okay.
So biphenotypic sinonasal sarcoma does have these downward respiratory glandular proliferations, but I would argue that even these cells are too plump. Nuclei are too plump. I don't see like that usually has very characteristic streaming spindled fascicles. Oh yeah, I see your question now. So I would say that is not a significant consideration in this case. And I believe on frozen, as I said, this was just called malignant, period, because of the somewhat, syncytial morphology, but it did turn out to be NPC. The second one, I'll just go very quickly. I just wanted to give you a second example of the same thing. And one of our pathologists a couple of weeks ago was lucky enough to actually have 2 of these in the same week. So here is perhaps a nicer example of what is also quite bad looking, with very prominent red nucleoli, large dyskeratotic cells. So this was a second instance of a nasopharyngeal non-keratinizing carcinoma, for which I've put the Eber. I'll let you review that case on your own. Okay. Oh, because it's 9 o'clock. All right. So the last couple cases I had were just more of the larger resection kinds of specimens. One was a tongue and one was a mandible. So we can perhaps pause these for another day. I do have a session in the week after USCAP that I was planning on doing, I think, salivary, but I could finish this instead, or we can tack on a 4th session, or even a half session, because I don't think these last 2 cases are going to take a whole hour. So I will leave it up to you guys. We can figure out how we want to organize it.
Either way, if we want to tack it on to the salivary, or if we can find a different date for like just a mini session with you, just to catch up. And looking at our schedule quickly here. So USCAP. So your next session is, I guess, the 31st, so last day of the month. And then you have another, no, you don't have another.
No.
Yeah, so we have an opening, openings on the 18th, the 25th, and the 28th of April. If any of those dates work for you, we can talk offline if you want about